Good afternoon and welcome everyone to this Retina South Africa webinar brought to you today on World Retina Day. We are very excited about today's presentation where the topic is Love Your Eyes, Know Your Eyes. I am Manny Moodley, chairperson of Retina South Africa, and I'm honored to be welcoming you all today. We hope to have a full house of people joining us virtually. Today we have a bit of a change in our program because unfortunately Karen Denton, our expert in AMD and diabetic retinopathy, is a bit under the weather. So instead of the two speakers, we have one speaker, but one very qualified and knowledgeable speaker in Claudette Medifant. Claudette is obviously a long-standing member of Retina South Africa and our head of science and patient services. And most of you would already have had some interactions with Claudette over the years. But yes, she is an expert in her field and she is known the world over for her great knowledge and depth of knowledge in the retinal field. I'd just like to kick off by mentioning a bit about World Retina Day. World Retina Day is an international day which is celebrated around the globe, and we take this day to focus on retinal conditions and how to improve awareness about retinal conditions and improve the lives of those affected by these retinal conditions. To honor that, us at Retina South Africa have decided to put on this webinar to give you some helpful tips and ways to protect the vision that you do have. We hope that you will enjoy. So without further ado, I'd like to introduce Claudette Medifant. Hi, Claudette, welcome.
Thank you so much, Manny. And I cannot let this go by. We've just had the good news that Manny has just been elected as the Deputy Chair to Retina International. And what an auspicious day for that to happen. So Manny, congratulations from all of us. It's so well deserved. Thank you, everybody.
Thank you.
So,
Thank you, Claude.
as Manny said, I'm going to substitute for Corin. So we would like to say welcome. So I would like to introduce you to our support staff and volunteers, Victoria and Carol and Karen and Denise and Lindiwe and I. And if you phone the office for counselling, you'll get one of us. We must disclose that we have an unconditional educational grant from both Bayer and Roche, and we thank them for supporting our awareness. So what is vision? Well, vision is how the brain perceives and interprets messages sent from the retina. The retina converts photons of light, which are reflected from objects in the visual field, and it converts these photons to a message which is sent via the optic nerve to the brain. So you see in your brain and not in your retina. And this is a side view of what the retina looks like and what the eye looks like. So let's first start with the eye. The light enters the front of the eye through the cornea. The cornea is that white layer in front of the eye that protects the eye and starts to focus, minutely focus the rays of light into a single visual image. Comes through the hole in the middle of your iris, which is the pupil, and then it comes into contact with your lens. Your lens is nature's spectacle, which further refines the focus of the light. The rays of light, which are now focused, go through the vitreous and then come into contact with the retina. And the retina lines the back of the eye, and this is where the magic of phototransduction actually occurs. So let's track this as if you can see this person who's looking at a picture, which is a photograph, actually one of Corin's son's beautiful photographs of penguins. And that picture goes onto the retina and then is transported via the optic nerve to the brain, which is where you see the picture of the penguins. So what visual tasks? Some visual tasks will use cones, some rods in the periphery, and some use both. So when you're looking with your fine focus tasks like reading, writing, using a computer, looking at a TV, or recognition of faces, that's when you're using your cone vision. Also, if you're looking at color vision, we have 3 types of cone that respond to colors, red, green, and yellow, to those colors in those particular wavelengths. And miraculously, out of those 3 color cones, your brain can see millions of shades of different colors. If we're looking distance vision, we're using both rods and cones, rods for the periphery, cones for the central. And depth perception, you need 2 eyes to give you depth perception, because your eyes see objects slightly differently, and your brain can then perceive that, hang on a sec, that object is further back. So if you've only got 1 eye, you won't have any depth perception. And then for contrast vision, you can see the picture on the left. For those of you who can see, it's got very poor contrast. It's white rice on a white plate, and I can even hardly see it. In fact, when I first opened Corin's slide, I didn't know that there was an image there because my contrast is so bad. But if you look at the image on the right, the rice is served on a black plate, and you've got that immediate good contrast. So remember that when you're serving meals to people with poor contrast vision. And night vision, we use only rods, and I don't believe anybody can see at night, because I don't think so. It's dark. How can you see? That's how bad my rods are. And then, of course, for peripheral vision, we also need our rods. So if you're looking straight at an object and you don't have peripheral vision, you'll only see the center of the object. And of course, with movements, you use rods into the center, cones, and then rods as the image leaves. So if you've got poor cones or poor rods, you will see you won't see, you will miss bits of people of information that comes in and out of your visual field. So how do they test vision? Well, visual acuity is tested by an optometrist, and it's the measure of the ability of the eye to see detail. And you see here, you see a very glamorous picture of me being tested by the wonderful low vision therapist in Johannesburg, Hazel Sakarowitz. So when you look at an eye chart, that's when you're testing visual acuity. So this is a Snellen chart, and it's good vision is 20-20-20, or as we say today in metric, 6-6-6. And low vision is 20/200 or 660. There's also the EDT-RS, which is a logmar, which a lot of ophthalmologists will use that terminology. And then, of course, you can also test your vision with using an Amsler grid. If you look at an Amsler grid and you focus on the central dot, all the lines should be square and straight without any blotches or imperfections. And the good news is you can always get an Amsler grid from Retina South Africa. So let's look at what is the loss of vision. You can have refractive error, where you need glasses or contact lenses to actually focus the light. Remember, we said that the light has to be focused on the retina to have a clear image. And if you don't have that clear image, you won't have good focus. If the image is focused in front of the retina, we call it short-sightedness. And if the point of focus of the light is behind the retina, we call that far-sightedness. And spectacles or contact lenses can correct that focus to give you clearer image. Cataracts. Cataracts are very common in retinal conditions, and it's where that lens that we said focuses the eye just after the pupil. If that becomes cloudy and the proteins within the lens become brittle, you get what we call a cataract in poor vision. And the good news, of course, is that it can be replaced. They cut open that little sac that contains the proteins, they remove those proteins and they insert a plastic lens. Be careful when you have cataracts removed and intraocular lenses inserted. Discuss with your doctor what lens he's putting into your eye. Is it going to be short focus or long focus? And people with retinal degeneration do not usually cope very well with multifocal or varifocal lenses, which are new on the market. I have got a lens of completely different focus in each eye and my brain puts that image together. So I've got one eye that's got short focus and one that's got a long focus, and it works very well for me. It might not for you, so please discuss it with your ophthalmologist. Glaucoma is another important loss of vision, where that vitreous that we spoke about, where the light has to go through, the pressure inside that vitreous becomes heightened. You get high pressures, and that can actually in time damage the retina and particularly optic nerve. So a simple test, a puff test by an optometrist once a year, can make sure that you don't build up pressure in your eye to such an extent that it will damage your vision. And you won't know till it's too late. So please be very careful, get an eye test. Then we're going to look at the retinal conditions like age-related macular degeneration, genetic retinal conditions, and diabetic retinopathy, which is what we're going to focus on today. So we're speaking about the retina. And remember, this is one of the most complex organs in the body. So we're starting here with the retina. This is the optic nerve. And then we get the neural layer. We get the photoreceptors, which are what we're particularly concerned about here. And then underneath it, we get the pigmented epithelium, Bruch's membrane, and then the blood supply. And all of this complicated series of layers of cells put into a layer, the total thickness is about 300 microns, which is about as thick as a piece of cellophane paper. So you know we're dealing with absolutely microscopic cells here. And this is an artist's impression of what the retina looks like. And it's actually easier to understand it if you see it in this kind of format. So the light enters, as we said, we showed you on that picture of the eye. The light is coming from the vitreous, and it goes through the optic nerve, through the neural layers, the ganglion cells and the bipolar cells, and it comes into contact with the photoreceptors. The colored ones, red, blue, and green, are not really colored. That's what they respond to. They're more concentrated in the center of the retina, which is the macula. The light reacts with these photoreceptors, and then a biochemical and neural signal is converted. Photon of light becomes a neural signal, and the biochemical changes, and this signal then passes from the photoreceptors to the horizontal cells, to the bipolar cells, to the amacrine cells, and then to the ganglion cells. And the tails, or the axons of the ganglion cells, group together, and they're very long, and they form these long chains, and they form the optic nerve, and they connect right through to the brain. So it's a very complicated story. I've marked the pigment epithelium to remind me to tell you that the pigment epithelium is a very important layer in the retina. It is the nurse layer and the factory part of the retina. It is not a neural cell. It doesn't actually connect to the photoreceptors, but they are in very intimate contact. So there's enough, the contact is so intimate that these chemicals and nutrients and waste products can actually flow back and forth. We are born with our full complement of photoreceptors. We don't grow new ones, but within those cells, we grow new little discs every night when you sleep, in your deep sleep, non-REM sleep. So those little discs within the photoreceptors need to be regenerated every night, and the regeneration happens between the photoreceptors and the pigment epithelium. I also have the neural cells marked to remind me to tell you that even when our photoreceptors are very degenerated and non-functional, these neural cells actually remain pretty intact, and that's very important for the research that's going on that we'll tell you a little bit about later. So let's look at peripheral vision loss, rod loss. So if you have got a rod loss, you've probably got either retinitis pigmentosa or Usher syndrome, type 1, 2, or 3, which is RP and hearing loss, or Leber's congenital amaurosis. It's such a long name. You see why we actually shorten it to LCA, choroideremia, or Refson's disease. And I've got a mark there to tell you about the diet in Refson's disease is very important. If you have been diagnosed with RP and you have a poor sense of smell or a funny toe, you need to go and have your fascination acid tested, because those are markers for Refson's disease. And if you exclude dairy products from your diet, you can actually stop the degeneration in Refson's disease. The symptoms of RP are poor contrast vision, night blindness, or very bad vision in subdued lighting, delayed light to dark adaptation, field loss when the disease progresses, and then later cone loss, because the rods produce a factor called cone viability factor that keep the cones alive. And that's also in clinical trials, and we'll talk about that a bit later. This is a picture of a retina, and I can actually publish this without contravening the POPI Act, because this is a picture of what my retina looks like. And you can see the dark patches where the photoreceptors have died and the pigment epithelium is showing through. And that's what my retina looks like from the outside. So you can imagine what it looks like from this side. And then we have central vision loss. We have the juvenile onsets like Stargardt disease, fundus flavomaculatus, cone and cone rod dystrophy, or achromatopsia. We have, of course, the age-related macular degeneration. The symptoms of cone loss are poor visual acuity, reading, writing, face recognition. Color vision is sometimes affected, but not always. And you have a tremendously variable age of onset and progress. And these are some pictures of what a Stargardt retina looks like. This is what we call a fundus photograph, and you can see the spots and the little dots and the white patches. This is what we call an autofluorescence photo, and you'll see in the retina a dye is injected, and as it progresses through the retina, they take it with a special camera, and you see all the little white dots. That is the build-up of lipofuscin in the retina, which is primarily the cause of Stargardt's. The cone photoreceptor death is secondary. And this is what we call a OCT. It looks like a picture of that sandwich, side on. And today, this quite new ocular coherence tomography imaging only started about 10 or 15 years ago, and they can now see almost individual cells in the retina. So it's a wonderful advancement in actually measuring and looking at the retina. Then let's look at age-related macular degeneration. Well, there are two kinds, which is dry or non-vascular, sometimes called atrophic, where you have a build-up of waste material called drusen in the macula. Now, again, it's not the same build-up as you get in Stargardt's, but it's a build-up of waste material that destroys the retinal pigment epithelium, and the cones are then compromised. And because Stargardt's and AMD share a common pathway, a lot of this research that's going to help with retinal pigment epithelium treatments that they are working on for macula will also help Stargardt's, which is good news for Stargardt's patients, because for every one Stargardt patient, you have more than 100 AMD, so it makes it financially viable to look for those kind of treatments. Then, of course, we've got the wet, which is the neovascular, where we've got new blood vessel growth in the macula, and the leakage of fluid or blood will cause serious vision loss, and this can be treated with anti-VEGF injections. So what are the risk factors for AMD? Your age. If you're old enough, you may be at risk for AMD. And as we've seen through the years, that age has actually got younger and younger, which is very frightening. Ethnicity is important. The lighter your skin, the higher your risk. Your family history, because we know it is the genetic disease to a certain extent. There are over 20 genes that have actually been linked to AMD. So if you have a family history, you need to get your eyes checked regularly. Smoking is one of the most dangerous things you can do for your vision, not only for AMD, but certainly for AMD. Your diet is important. And we know if you have a cardiovascular disease, you're at higher risk. And here you can see the build-up of the waste material in the retina, and that's a fundus photograph of a retina in AMD. Then we get to diabetic retinopathy. It's caused by excess glucose in the blood. Excess glucose in the blood, we know, damages organs and arteries. And those tiny, tiny blood vessels in the retina show damage long before the blood sugar levels even rise. And this damage can lead to severe vision loss. Anti-VEGF injections may also be used to treat diabetic retinopathy. But prevention is far better than a cure. And prevention is by having a healthy lifestyle, a colorful diet, no simple carbohydrates, no sugars, less red meat, and very importantly, exercise. So this is the risk factors. It's type 1 or 2 diabetes. If you have diabetes long enough and it's not controlled, you will probably develop diabetic retinopathy. So you need to control your diabetes. Your diet is absolutely important. And exercise is terribly important because exercise helps to move the glucose from the blood vessels into the muscles, which is where they should be. And again, smoking is a risk, and cardiovascular disease. And we have a new reality now because researchers now verify that COVID-19 infection increases the risk of diabetes. And this is the latest research from Minnesota University that says type 2 diabetes rates in America, the young people rose by 62% after COVID pandemic. That's really frightening. And that was now released now, September 22nd. This is 2023. This is new research. And type 1 diabetes increased by 17%. But it's not only for the youth. These are all the research articles that Corin has cited, and if anybody's interested, you can certainly send us a mail and we will send you a copy. The risk for diabetes is very real, so you have to make sure that especially if you already have a retinal condition, that don't develop diabetes. So let's talk now about treatments. Well, treatments come from clinical trials. And how do they run? What are clinical trials? Well, clinical trials are actually studies, tests done on volunteers to answer specific questions. And the most important question they have to answer is this intervention safe? There's no point in treating a retinal condition and you cause a cancer in the eye or something. And then secondly, is it effective? And these studies can be drugs or vaccines or other interventions. And the latest thing they're looking at now is repurposing drugs that have been used for some other condition that now may have an effect on helping retinal degeneration. And these clinical trials have to be monitored by a monitoring authority. In South Africa, that's the Department of Health, and in America, and I'm sure you all know about the FDA for those endless COVID interviews that the FDA had on TV, so we all know the importance of the FDA. Clinical trials are done in 3 phases. The first phase is very small numbers. You could have to be close to the clinic because especially if it's a new intervention like a stem cell or a gene therapy, you have to be monitored very closely. They have to check you every couple of weeks to see if it's safe. If it's safe, and the outcomes that they had to discuss with the monitoring authorities up front, if those outcomes are met, then they, with permission, once the results have been analyzed, can go on to phase 2 and 3 clinical trials with increasing number of patients. And then they look at other things, perhaps like dosing issues, and always, is it safe? And very often, phase 2 and 3 clinical trials can go to multi-center trials because these are rare conditions. They may not have enough patients in that area, and then it will go to other areas. And that is how we were able to get onto the Stargardt trial, which ended last year, which was a multi-center trial. And the good news is that from our patient registry, we were able to recruit over 400 people to go or to be evaluated for the trial. And eventually that was whittled down to 30. It might sound very few, but it was actually the highest number of patients in any one of the 30 sites that were involved in the trial. So we did very well. Unfortunately, the drug didn't. So what are the results from treatments? Well, there's 2 possible scenarios. Perhaps the treatment will retain your vision. And gene therapy would be one of those. Gene therapy delivers a working copy of the gene to the eye. So it's not going to give you new photoreceptors. It's going to change the code that the cell uses to produce the protein that the photoreceptors need. And if you've got a recessive condition, you've got a double copy of a gene that doesn't work, and gene therapy replaces it, puts in a working copy of the gene. Or it can deliver a gene that produces a therapeutic protein, and we look at that in optogenetics. And of course, gene editing. Gene editing sounds very complicated, but it's like cut and paste on your computer. If you've made a mistake and you want to edit that section of text out and replace it with another section of text, gene editing does that, but of course it's doing it in the gene in the chromosomes. Then, of course, we can also have therapeutics like drugs or antioxidants or that rod-derived cone viability factor that I'm really interested in because I've got good cone vision, but no more rods. And then there are other areas of research that we're very hopeful about that will restore vision, such as stem cells. And we know that induced pluripotent stem cells can be grown from the patient, or we can have stem cells grown from embryonic cells, and they're growing new retinal pigment epithelium cells, and they're trying to grow new photoreceptors. And then we get optogenetics. Remember, I spoke about those layers, that neural layer of cells in the retina, that even though the photoreceptors are dying or inactive, these cells, the layer of cells, can be induced to become light sensitive, and they do it by introducing light sensitive molecules to either the retinal ganglion cells or to the bipolar cells. And these are very exciting research. So this is a copy of the clinical trials pipeline from the American Foundation, fightingblindness.org. We're not going to go through all of these clinical trials because we'd actually be here for the rest of the day. So you can see, if for those who can see, achromatopsia, AMD, Batten's, choroideremia, LCA, RP, retinoschisis, AMD, Usher's, Stargardt's, AMD, Usher's, LCA, Usher's, again, in areas like gene therapy or RNA and cell-based therapy. So if you go and look at fightingblindness.org, go and look up for your condition, and then go to clinicaltrials.gov and go and see exactly who's doing and where, in what stage it is, and you'll get a lot of information about your own condition. So what causes retinal degeneration? We know that genetic mutations produce toxic or missing proteins, and this causes cell death or inactivity of the photoreceptors and vision loss. And they can also cause misfolded proteins or waste products that clog the cells. And you saw that picture of a retinal cell. So you can imagine these are minute cells that are very closely packed. And one misfolded protein can clog up and result in death of adjacent cells down the line. Well, there are more than 300 genes that already have been implicated in retinal degeneration. And that's quite a burden of disease. It's not one condition. Somebody said, is RP one condition? And in fact, it's really not. Retinitis pigmentosa is probably one of 90, because there are 90 genes that have been associated with retinitis pigmentosa alone. So RP is not one condition, it's actually 90 different conditions. And these genes can express in any of those cells that we saw in that photograph, in the pigment epithelium, in the photoreceptors, in the neural cells, and even in the choroid. The retina is one of the most metabolically active sites in the body, and it doesn't handle misfolded proteins or mutations very well. So let's look at gene therapy. In recessive or X-linked inheritance, it can be used to replace a faulty gene with a working copy of the gene, and that little section of DNA, the gene, is delivered by a viral vector, an adeno-associated virus. Or you may use a viral vector to deliver a gene that can produce a therapeutic substance, like in optogenetics. The problems are it's not for dominant conditions, because in dominant, you've got one good copy of the gene and one bad copy. The good copy is still there, but the proteins that the bad copy makes almost overwhelm the cell. So you'd need to knock out the dominant gene first and then introduce a working copy. So it would be two genetic interventions in one. And large genes like the Stargardt gene, the ABCA4 gene, do not fit into that adeno-associated virus. And they're now looking at splitting the gene and putting it into a double AAV and then hoping they will regenerate and reconnect in the retina. And that's what's an adeno-associated virus. I didn't want you to think of a coronavirus, which we all know what it looks like. This is slightly different. Every living organism has DNA. So what they do with this AAV is they go into the center of the virus and they remove the virus's DNA. They insert a working copy of the gene, and viruses replicate easily, so they make thousands of copies of the gene, and that's injected into the retina. For those who can't see it, I'll explain in the slide. We have a syringe that contains thousands of copies of this virus containing a new copy, a working copy of the gene, and it's delivered to the retinal pigment epithelium layer of the cells. And I think it's miraculous that the RPE says, hey guys, look, we've got a new code, let's try it. And they do, and they make the correct copy of the protein. So what are the problems and promises of gene therapy? Well, gene replacement is only for one gene, so it's gene specific. And as we said, there's over 300 genes, so they would need 300 to develop 300 interventions. And you can imagine the costs of development and the treatments are exorbitant. The conditions are rare, and sometimes there's not even enough patients to actually develop the gene therapy. We have one gene therapy that has been registered. It's called Luxturna, and it's for the RPE65 gene that can cause either Leber's congenital amaurosis or early onset RP. And it is available in Europe or America and now recently in Canada. And the cost per eye is about 13 million rand. So you can see it's not coming to South Africa anytime soon, unless you all do a lot of very active fundraising. Some side effects of this gene therapy have been discovered, but it does work well in recessive conditions, and only a single treatment is required, and hence the cost. Let's look at a gene therapy that is in clinical trials for X-linked RP. It's a phase 2/3 clinical trial by Vista. It was owned by AGCT. The gene therapy is still called AGCT 501. It's for the RPGR gene. So if you're sitting out there and you've got X-linked RP and you don't know which gene you've got, you know who to call. One of the criteria is obviously male, because it's X-linked and only males are affected by X-linked conditions. Age is 13 to 50 years old. And for people under the age of 17, the visual acuity has to be 20/32 or 20/200, which is 6/60. The control group will have a placebo. They are so sure of this therapy that they've offered the placebo group after a year that if they like, they can switch to the drug, which is really wonderful. It's double masked, and if you read that, you know that means that neither the patient nor the doctor knows who's getting a placebo and who's getting the drug. And if you're interested, you can go and look at beacontxhcp.com. You can take a screenshot of the clever ones, and that is where you can go and look up exactly what's happening in this AGCT 501 therapy trial. Let's look at stem cells. Well, stem cells are pluripotent. They're early embryonic cells, they're super cells, they can and do become every cell and any cell in the body. And induced pluripotent stem cells can also be grown from the other body tissue like skin or blood. Researchers are growing new retinal pigment epithelium cells from stem cells, and they're also trying to grow photoreceptors, but not so successfully. The problems and the promises of stem cells. Growing neural cells still is not viable at this stage. They're hoping for And it's going to be really important step forward in many areas of health when we can grow neural cells from stem cells. If you're using donor cells, there's a very high chance of rejection. And the stem cell reproducibility from lab to lab is not that consistent. So they have picked up some problems. And of course, it's very, very costly. The promises, a cure, perhaps. One day, maybe we'll all get new photoreceptors from stem cells. And it will work for many genes. So the gene does not matter. There's a very interesting stem cell trial for AMD. And it's called regenerative patch. And the name is CPCB-RPE1. And they use an artificial scaffold to grow new retinal pigment epithelium cells. And the cells are grown from human embryonic stem cells. And it's phase 1/2. And that patch is actually inserted into the retina to provide new retinal pigment epithelium cells so that the photoreceptors can get the nutrients and the waste disposal that they need. So it's very exciting. And remember what I said? For Stargardt's and AMD, although for different reasons, if you've got new retinal pigment epithelium, hooray. And let's look at pharmaceutical intervention. Well, we know that anti-VEGF injections for AMD and diabetic retinopathy do work. There are very good trials going on for vision-disrupted drugs to slow Stargardt vision loss, and also vitamin A dimers to minimize the vitamin A damage in Stargardt's. And then antioxidants, lutein, and zeaxanthin, alpha-lipoic acid, and L-glutathione are absolutely imperative for anybody who has got a genetic retinal condition. And I'm living proof. Most of my family my age don't have any vision, and because I've been on them for 15 years, my loss of vision has been minimal. And then, of course, the new guys on the block are NAC and NACA, which is N-acetylcysteine, and they're both in clinical trials. And researchers always used to say that oxidative stress is very crucial at end stage retinal degeneration. But they're now realizing actually that it's also very, very important in the beginning. So please take antioxidants. Let's look at photoswitches, which is optogenetics. We said that neural layer is largely intact, and all we need to do is perhaps confer light sensitivity into those neural layers. And they are putting light responsive molecules directly, delivered them mostly by gene to the neural cells. And the interesting one is bionic sight, which was first started by Professor Sheila Nirenberg. A light-sensitive protein is delivered to the retinal ganglion cells. And then there's a special pair of spectacles with a little processor on the side, and it sends a neural impulse to the ganglion cells. Because Professor Nirenberg has always said the problem has been with the artificial retina and other types of optogenetics, they're trying to shine light into those light-sensitive molecules, but they're not making the connection. So you need to code the light into a special wavelength. So this they are doing, and then the retinal ganglion cells actually send the message to the brain. 12 patients have been treated with this gene therapy and the glasses, and out of those 12, there have been 4 people who really excelled. They have the best improvement in recognizing shapes and objects with an 80% success rate. And this is one of the few successful ones. So this type of therapy is really moving at a very fast pace. And again, it's gene agnostic, so it's going to help people with many gene mutations. And it is already restoring some sight to people with advanced vision loss. How do you cope with vision loss? Well, I hope like me, you have electronic devices like magnifiers, and you have special computer programs and settings on your computer. And we have Steve Jobs to thank, because on our smartphones, we have got free voiceovers or Zoom, where we can really use our smartphones to really communicate very effectively. There are wonderful apps. When you go on our website, you can see a list of about 100 apps that you can use. My favorite app is Be My Eyes, where you actually connect to it. It's an app, free, and anywhere in the world, I think 1 million or 2 million, one of those volunteers will answer the phone and will actually be your eyes. They will see through your phone camera and read menus and tell you what gate you have to go to at the airport or negotiate through difficult circumstances. It's really important. The equivalent in artificial intelligence is seeing AI, but I prefer Be My Eyes. Then please have mobility training if you need it. Even if you have a simple cane, if you just need it around the house, a mobility trainer can also come and give you skills for daily living. Regain your independence and ask for assistance when you need it. If you're shopping, if you're going for a big shop, phone the day before and request a shopping assistant. And I promise you, all the big chains will provide one free of charge. If you're traveling, when you book your seat, book assistance. How can you protect your vision? We know about ultraviolet light. You need good sunglasses. But remember, all your devices also emanate blue light. And you need to make sure that you protect your vision from that blue light coming out of your electronic devices. There's a 20-20-20 rule. Don't look at a screen for more than 20 minutes. Look away for 20 meters for at least 20 seconds, and then blink 20 times, because dry eye is very common in South Africa, and blinking actually helps you to lubricate your eyes. Please, no smoking or vaping. Vaping is just as bad as smoking. It really is very bad for your eyes. We know that antioxidants do slow the rate of degeneration, like Retina Plus for inherited retinal degenerations, and Ocuvite for AMD, and no vitamin A for people with Stargardt's or cone rod dystrophy, because it really will increase the rate of degeneration. And if you're a smoker and you're taking vitamin A, it increases your risk of lung cancer astronomically. Reduce food additives, preservatives, flavorings, artificial sweeteners, and colorants. If you look at a label of processed food and you don't understand what's on the label, please put it away. Don't eat it. Don't drink it. We know that all those artificial drinks contain high levels of sugar. So don't put yourself at risk for developing diabetic retinopathy as well as an inherited retinal degeneration. You need a healthy diet. Eat from the colors of the rainbow, or as Karen likes to say, from the colors of our flag. Your food on your plate should be colorful, and cut down on simple carbohydrates. And you need physical fitness. You can stand in your room, hold on a chair, and run on the spot. You can move as long as you move. And sleep is very important during those hours between 11 and 3, when you've got non-REM deep sleep. Remember, I said those photoreceptors are regenerated and your brain is actually cleansed as well of toxins. So stress, let's face it, when you have a retinal degeneration, it's stressful. But you can control and break that cycle of stress. Effects of stress are anxiety, insomnia, poor decision-making, poor eating habits, short temper, isolation, and it affects your vision. What can you do? Exercise, get at least 7 hours of sleep and no screens in bed, healthy foods, and eat as early in the evening as possible. Meditate. Meditation has a 20% reduction on your stress immediately after about a week of training. Listen to soothing music, walk in nature, gardening, swimming, and of course my favorite, yoga, because I'm a yoga teacher. Yoga is a great de-stressor. So the take-home message is, have an accurate clinical diagnosis. You should know what your condition is, and have regular eye tests. And of course, if you're having anti-VEGF injections, listen to your doctor, go for your injections. If you've got a genetic condition, know your code, get a result, know exactly what your condition is. Support Retina South Africa. If you're not listening from South Africa and you don't have a retinal group, start one. Register with myretinatracker.org, preferably with a genetic result, and that allows researchers to find you. Support us by nominating us as your beneficiary at www.myschool.co.za. You can have up to 3 beneficiaries. If you know rich people, please get them to donate to us, because we do have tax-deductible donations. And please support us with your membership fees. I would like to thank you very much for listening to me. And if you want to contact us, our website address is retinasa.org.za. Our email address is headoffice@retinasa.org.za. You can call on our share call number, which is 0860 595959, South Africa only. And thank you very much.
Thank you, Claudette. That was informative as always. I've listened to variations of the speech many times, and it's still fascinating each time. So, yeah, it's fascinating each and every time. Thank you for that. I think there are a few questions which have been put through during the talk.
Yeah. Do you want me to take them? I'll try not to cough.
Yes, please, Karen, if you can, that would be great.
The first one is, how can one prevent pressure buildup in the eye? Any precautions?
Well, there are two reasons why you have pressure buildup in the eye. One is a family history, and the other one can be from drugs, and otherwise they don't know. The only way you can make sure to reduce the damage is by actually having your pressures checked regularly. In the early stages, you can actually, even just by an eye drop and then by tablets, can actually control that pressure. But if you leave it too long, you might need an operation where they actually introduce a little channel, they actually implant a little canal to actually drain the fluid out of the eye. But it's not always successful. And again, with glaucoma, honestly, prevention is truly better than cure. Have you got anything to add to that, Karen?
I think that answers it. The next question, sorry, is, do you have to be paid to be part of a clinical trial?
We were running out of time. We have a wonderful slide about that. That you won't be paid to be on a clinical trial. Your expenses will be met. But on the other hand, you shouldn't be charged. If you are charged to be on a clinical trial, it's not a clinical trial. It's somebody making money out of you. And remember that a clinical trial will only be at the clinic where the trial is instigated, or as we said, if it's a phase 2 or 3 where it's a multi-center trial, it could come. So we want to bring clinical trials to South Africa. So the more people we have registered with Retina South Africa with a genetic result, the more chance have of bringing those clinical trials to South Africa. But no, you can't go and get paid for a clinical trial.
Exactly. And then, do you need to take Retina Plus supplements if you have any type of retinal condition? Or does it have an impact on your other normal vitamins that you take?
My reply to that always is the only vitamins that I take are the antioxidants that are in Retina Plus and NAC. If you're taking a multivitamin and you do not have a genetic diagnosis, and that multivitamin contains vitamin A, then you're in for trouble. The multivitamins are at such a low level and they're synthetic. I think it's more important to get your nutrients from your diet. Rather eat fresh, healthy vegetables, and you will get all the antioxidants and vitamins that you require. I wouldn't recommend that you just go and pop multivitamins. To me, it's not doing much for your eyes, and I don't know how much it's doing for the rest of your body, unless you are obviously deficient in something, and then listen to your doctor.
And then, may I ask if Orcam glasses can assist a Stargardt patient? And what is the name of the drug can assist in reducing itching eyes?
Orcam Mani will talk to, because you've got an Orcam Mani. Have you used it?
Yeah. Yeah, no, that is actually quite useful. It depends how much central vision you still have. If you do have some central vision, it can assist. It's essentially a text-to-speech converter, which sits on your glasses, on the frame of your glasses. So it talks into your ear. So things like menus can be read quite easily through the text-to-speech function, or you can take photos of things and store them for later. So yeah, you can use it as both a magnifier or a text-to-speech. It is useful. But, we always would say in these circumstances, it's best to test out devices before buying, because everyone has a different range of vision, and it really is very user specific. So please test them out. And there are a lot of low vision optometrists and ophthalmologists and centers that sell low vision assistive devices where you can test them out first before purchasing, because they are really expensive.
Absolutely. Karen, the second one was what?
Itching eyes.
itching eyes. Itching eyes can be caused by an allergy, by so many different causes that you really should consult an ophthalmologist. I think that if you've just got dry eyes, blinking will help. But if you've got an allergy, you might need to get some specific allergic, anti-allergy eye drops. So yeah, we can't diagnose you. We haven't even seen your eyes. So please always remember, see an ophthalmologist. Don't mess with your eyes. Know your eyes and go to see someone who knows your eyes even better than you do, perhaps. Thank you.
And the questions
Thanks.
are piling in. If they cannot find the markers to pinpoint your condition, yet diagnosed as in infancy, what steps should now be taken?
Okay, now remember that if you had a genetic test many years ago and you didn't find a gene, remember you should retest. Somebody said the other day, I think it was on the American Foundation Fighting Blindness webinar, and they said every 5 years. Because, in the interim, they could have found your gene. If they haven't found your genetic mutation, was it ever tested? Was it tested properly? And maybe it's time for a retest. And remember that for needy families, Retina South Africa will consider giving some sponsorship to really needy families for genetic testing.
Thank you, Claudette. And then the next question is one that I'm often asked, actually, and that's about the retina and the macula. Is the retina and the macula linked?
Corinne, you had a voice, you would have answered that. The macula is part of the retina. It's the central part of the retina, and the very center of the macula is what we call the fovea. And the fovea is where you only get cones. So it's like saying, is a finger a part of the arm? Is the arm a part of the body? Yes. Eye is the overall structure. The retina lines the back of the eye. The center part of the retina is the macula, and the very center of the macula is the fovea.
Thank you. And then Michelle says, are you able to test devices and apps without buying first? As far as I know, they all do, but you can comment.
With apps, there may be a demo or trial function that you can trial for a few days, perhaps before purchasing. But there are also a lot of free apps that are available in terms of magnification, screen readers, and that sort of thing. Look out for those and check our website for that information. We have a long list, as Claude mentioned, I think over 100 apps. With devices, assistive devices, you can go to places like Sensory Solutions, or Edit Micro, where they do have devices on site that you can test and then have a better understanding of what the device does and how it works and how it can assist you in your day-to-day.
And I think, for example, Zoom Text, which I know you use many, which is a very powerful screen reading program, you can actually get a free 2-month trial before you buy.
Yeah.
So always try before you buy, especially if it's an expensive item. But
Definitely.
a lot of the apps are free. So, I mean, Be My Eyes is Seeing AI is free. The
Vision AI also is free. A lot of apps available on the market, and a lot of the smartphones and laptops, Macs, PCs come with software which is already on the device and free to use, which can assist with a lot of different needs. So yeah, it's important to see what works for you and find the best solution. We're happy to help with that. So,
and remember that there's also a free screen reading program called NVDA, which does, I don't think it's as good as perhaps JAWS, which is a very expensive program, but it's free. And I've heard people who are actually in computers, so for coding, NVDA is actually better than JAWS. So talk around and, contact us. We can always put you in touch with someone who's using that particular device. Don't buy without trying. That's a very important thing.
Thank you. And then, do bioptic telescopes help with driving for star guards? And that's a difficult one.
Well, I think that it helps some people, but you have to have special training. And I know only certain low vision optometrists will actually even consider you. I know that Hazel does do it, and there are some other low vision optometrists who do it. Ask your low vision optometrist, but don't have your hopes up, because it's, especially if you live in a busy city, I think I don't know. I've only heard of one person who actually drives successfully with it. So, yeah, it's all worth trying.
And then Claudette, the next one is a challenging one for us. Do we have offices for Retina South Africa in Nelspruit?
No, but we'd love someone to start one. I don't know if our chairman has anything to add to that.
Yeah, we don't have offices in Nelspruit, but there are a lot of members we have throughout the country, and we encourage the setting up of support groups, volunteer support groups, where it's just a coming together of a community within a particular geographic area, just to share and provide assistance to each other. Sometimes that the simple thing of just talking about your visual condition with someone else who understands or has an idea helps quite a bit. So we do encourage the setting up of support groups. We are looking at ways and means to get back into all the provinces. But yes, at the moment we are quite effective operating from our head office, and we can assist you virtually with sessions, counseling sessions. We can set up sessions with our social workers as well. So yes, please contact us for anything you might need.
Absolutely. And I had a very successful counseling session on Friday with somebody on Teams. And it was really, I mean, we were sitting talking, like we're talking to you, like talking to each other. And we can have one-on-one, virtual or telephonic, and we're always there. So please give us a ring or contact us through the website, and we'd be very, very happy to help.
Thank you.
Great.
And then what are the antioxidants that can be taken by someone with RP without vitamin A?
Retina Plus, which contains lutein, zeaxanthin, alpha-lipoic acid, and L-glutathione. And it's info at Eyes for Life, rp.co.za.
We are often told that macular dystrophy, not degeneration, is irreversible and currently has no cure. We are told to preserve sight. Any suggestions how one can prevent further damage to the macula in the case of dystrophy?
Okay, macular dystrophy is actually a generic name. It could be Stargardt's, it could be fundus fovimaculatus, it could be cone dystrophy, it could be cone rod dystrophy. And again, that Retina Plus is very good. And all those things that I said, good diet, good sleep, exercise, look after yourself, because the treatments are on the way. But if you take antioxidants, you look after your diet, you avoid fast foods, you can preserve your vision. You can look after whatever vision you've got. Thank you very much.
Thanks so much. I think it's just important at this point. We have lots of questions, and I'm sorry that we've sort of run out of time. We can't get to all of your questions, but what we will do is respond to you all, and maybe we'll put the answers up on the YouTube.
Could we perhaps use this as a promo, and we don't have to put it up on the YouTube, to say that we're with the South African Optometric Association. We're doing a big walk for sight.
Yeah, 12th of October.
Carry on. It's at Merendale Wine Estate in Durbanville, from 10 o'clock in the morning till 2 o'clock in the afternoon. And the proceeds are going to Retina South Africa and Guide Dogs. And if you live in the Cape, please come and support us.
Yeah, it's a free entry. It's a 5K fun walk, and it's amazing I think, initiative by the South African Optometric Association. So please check out our website for more information on that. And I think it's going to be a great event. So yeah, thank you for that. I just want to sort of round off by saying that all the information given today is advice provided by Claudette, who has a lot of experience and expertise within the retinal field. However, we are not medical doctors, so we encourage people to always consult your physician, your ophthalmologist, optometrist, for your specific needs, because everyone's condition manifests differently, and there may be other medical issues as well that need to be considered before taking any particular course of action. So please always contact your medical doctor for information. But yes, thank you very much, Claude, for your information today. I think it's been very informative, and I think we've answered a lot of the questions, and we hope that the viewers enjoyed the content. But please visit our website for more information. We have a lot of resources available through our website. That's www.retinasa.org.za, and you'll be able to see all of our initiatives, events, and also how you can get involved and support as well. And we greatly appreciate all of your continued support. Thank you very much for joining us today, and we will see you at the next webinar. Thank you, everyone.
Thank you. Bye, everyone.
Bye-bye.